Hi, myself Dr. Reha Rakhulia. I am third year MCH student of reproductive medicine and surgery, and today's topic is empty follicular syndrome. I have taken this mainly from share topic mainly from the textbook of Gardner and Kamini Rao, and there is one article from RBMO, empty follicular syndrome revisited, and one article from human reproduction. I have taken reference from these four things and I have made a video. Let's get started. Today's topic is empty follicular syndrome. Empty follicular syndrome is failure to retrieve oocyte. There are follicles in the ovary, but we are unable to retrieve after OPU. We are unable to retrieve any oocyte, no oocyte. Okay. In spite of having normal follicular development and normal estradiol level. Estradiol level should be 1000 to 4000. And now how will we see normal follicular development? We'll see normal follicular development by serial USG. Okay. Now what is there? It is a significant challenge in IVF leading to unsuccessful retrieval because it is a very stressful conditions. Because how will you explain the patient that there is no oocyte retrieved after OPU? Okay, it's very difficult to explain the patient. Then there is this is a follicle. These are mural granulosa cell, and around the oocyte there are cumulus cell. This is cumulus cell and this is mural granulosa cell. Okay, so during follicular development, cumulus cells surround the growing oocyte linked to mural granulosa by junction. These two are linked with junction. Okay, cumulus and mural cell. The LH surge mimicked by HCG either will give HCG trigger, which is a surrogate for LH. Which is a surrogate for LH. What does that mean? That it because there are two units, okay, alpha unit and beta unit. Alpha unit is identical in both HCG and LH, but beta unit is different. So because of this identical alpha unit, it can act in HCG can act in LH receptor and act as LH surrogate. Okay, so in spite of giving LH, we'll give HCG. So it will cause an LH surge-like situation because it will act in the LH receptor. Second trigger is GnRH agonist trigger. What does GnRH agonist trigger does is trigger. It will squeeze this is pituitary. It will squeeze the LH from the FSH and LH from the pituitary. Okay, that will cause LH surge. Both mechanism of action we have seen. So the LH surge mimicked by HCG and GnRH agonist breaks these junctions, which is between cumulus and mural granulosa cell. These two break this junction, allowing cumulus oocyte complex to be aspirated. A successful final trigger is crucial for detaching the COCs from the follicular wall. This cumulus oophorous complex should be detached from the COC for successful oocyte retrieval. Okay. Now, this is one diagram. It was in mouse. We found that before pre-LH surge and post-LH surge. We saw pre-LH surge, mural granulosa secrete some of the factors, and cumulus secretes other factors. But post-LH surge, cumulus starts secreting different factors which help in the cumulus expansion. Okay, so that means LH surge is important for cumulus expansion and oocyte retrieval. This was a study in mouse. Then oocyte follicular crosstalk. ठीक है, there should be cooperation between oocyte and follicular cell in growing follicle. Okay, there should be cooperation. Oocyte and follicular cell in growing follicle should be oocyte. This is oocyte and the follicular cell. Okay, these follicular cells should be in a cooperation. Okay, okay. So what happened is oocyte regulate cumulus cell. Oocyte regulate cumulus cell by two things. Two factor we have written, but many factor it can be. It can regulate the cumulus cell, but two factor here I have given, that is GDF9 and BMP15. Okay, this way oocyte regulate cumulus cell. And how does cumulus cell regulate oocyte? By coordinate oocyte development and maturation. First of all, it coordinates oocyte cumulus cell. Okay, then it provide energy for what? Energy for resumption of meiosis. Okay, then what? Oocyte also for regulate oocyte transcription. Then it promote nuclear and cytoplasmic maturation of oocyte. Okay, this way both oocyte and follicular cell help each other, cumulus cell. Now, variants of EFSs. There are two variants of EFS, empty follicular syndrome, that is genuine, and another is false. Okay, what does genuine means? Genuine means it oocyte not retrieve in spite of giving a correct trigger. In spite of giving a correct trigger and optimal HCG level or optimal LH level 12 hours after agonist trigger. Again, I'm explaining. Okay, genuine. First, we'll talk about genuine. No oocyte retrieved. Okay, no oocyte retrieved in spite of correct triggering. And how will we know correct triggering? If I told you before, there are two type of trigger: HCG trigger and GnRH agonist trigger. If we have used HCG trigger, there should be optimal to say it is a genuine empty follicular syndrome. HCG should be optimum. Some study says 10, some study says 20. Okay, optimum HCG level. And GnRH agonist, LH should be optimal. Optimal LH should, if we talk about GnRH agonist trigger, LH should be optimum after 12 hour of trigger. Okay, trigger. If we talk about HCG trigger, HCG should be optimum. If we talk about GnRH agonist trigger, LH 12 hour after trigger should be optimum. We usually take more than 15 to be optimum. Okay. So this is genuine EFS, genuine empty follicular syndrome. What does that mean? Even if the trigger are working, okay, like HCG trigger is optimum and GnRH agonist LH is optimum. Even if the trigger is working, still we are unable to retrieve oocyte, even if trigger is working. And what is false empty follicular syndrome? same, no oocyte retrieval after incorrect trigger administration, either incorrect trigger administration. Etiology I'll explain later on in detail. Here, incorrect trigger administration or or technical error or decreased bioavailability means there is something that trigger is not working. Like trigger is not working. In genuine, trigger was working, but still we didn't get any oocyte. But here, trigger is not working. Like we have administered trigger any different way, or there is a technical error like air leak in the pressure system. Like during oocyte retrieval, there is pressure system. There is air leak in that. There is decreased pressure. We have applied less pressure than normal, like that technical error is there, or there is a means that can be saved. The cycle which has false retrieval, that can be saved. Okay, salvaged that cycle. In this there will be decreased bioavailability. In this there will be absence or there will be suboptimal HCG. जितना लेवल होना चाहिए HCG का, the level HCG should be, that won't be. There will be suboptimal HCG, or there will be absence of HCG or suboptimal HCG. Okay, optimal HCG. Huh? Or that this we are talking about HCG or improper agonist triggering. Okay, either HCG is wrong, or there is improper HCG agonist triggering. In genuine empty follicular syndrome cannot be rescued with a repeat trigger, making the cycle unsalvageable because HCG is working. Still, there is not HCG or agonist trigger is working. It's still we are unable to retrieve the oocyte. That means even after giving a rescue dose, we won't be able to retrieve the oocyte. And second is false. It is a unlike genuine EFS, false can be rescued. False can be rescued with the repeat trigger enable successful oocyte retrieval. Okay, lack of standardization. Now, some study says that optimal HCG level after HCG trigger is like 36 or 37 hour after HCG trigger. ठीक है, 36 hour after HCG trigger, it is said that some study says 10 is the optimal level, some study says 20 is the optimal level. There is no standardization. Okay, so lack of standardization. No standardized threshold for circulating HCG level to define the correct trigger. There may be wide range, 5 to 160 international unit per liter report by different investigators to different GEFS and false empty follicular syndrome. HCG trigger, what and Dukwi et al. He said that cutoff is 10 milli international unit per liter, 36 hour after HCG. After HCG administration predicts 100% sensitivity and specificity. What does this mean? See, we gave the trigger, HCG trigger. We gave the trigger. We planned OPU after 36 hours. Planned OPU. If the value is less than 10, means there is 100% chance of EFS. Okay, that means trigger has not worked. there is something wrong with the trigger administration or something is there. Anna, trigger administration is not good. Bioavailability, like cold chain was not maintained, or like it is something is wrong. Etiology, I'll explain later. Okay. So that means if after 36 hour, um, uh, OPU is done and no sites are retrieved, then we'll do HCG. How will we do HCG? Either we'll do blood HCG because report will come later. That's why blood HCG is not done. We usually do UPT test, urine pregnancy kit test. If that comes to be positive, we considered that HCG was optimal. If that, okay, and if it is negative, then that there was something wrong with the trigger or something. So that's considered as a false empty follicular syndrome. Means something was wrong with us, like we were not able to give trigger properly or that way. Okay, but cycle can be salvaged if the patient has false EFS. Now at okay, this incidence, Stephen et al. What does Stephen et al. Said? Stephen et al. Said that if empty follicular syndrome is 100, then genuine empty follicular syndrome is 33% and false is 67%. This was said by Stevenson et al. In 2008. Now, risk factor and mechanism of empty follicular syndrome. What are the risk factors? Risk factor is this we can learn from a mnemonic, that is poor empty follicular syndrome. Poor previous history of empty follicular syndrome. O, obesity. These are the risk factor for empty follicular syndrome. O, ovarian resistance. Okay, ovaries resistance to stimulation. Then R, reduced ovarian, diminished ovarian reserve or reduced ovarian reserve. Okay. E is elevated FSH. Elevated FSH. F is decreased failed estradiol response, means low estradiol. Estradiol. S is senior age, senior citizen age. Means advanced age, old age. These are the risk factor. Okay. What is the, these are the risk factor. We can remember it with the mnemonic poor EFS, empty follicular syndrome. Then mechanism is either ovulation has occurred prematurely. Okay. Ovulation has occurred prematurely. If ovulation has, this was a follicle, this was oocyte. What we do in OPU is, this is follicle, this is oocyte, this is follicle, this is, one needle is passed through this follicle and this is sucked. This is sucked, and through this needle we collect it in the tube. So we collect the oocyte in the tube. But in premature ovulation, it has already ovulated. Now there is nothing in the follicle. It has come outside. Premature ovulation has occurred. So we won't get anything in the OPU. Okay. Second is low bioavailability of HCG. How can there will be low bioavailability of HCG? Either the cold chain is not maintained, or there is bariatric surgery or something. Okay. Or if there is very loose skin. So it is said that if there is very loose skin, subcutaneous won't work. Okay. Subcutaneous won't work if there is very loose skin. Why in bariatric surgery there will be low bioavailability? Why? Because of after bariatric surgery, there will be loose skin. Okay. So subcutaneous injection does not work. So we give IM injection for that reason. Okay. 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 Now Timing issued for HCG admission to oocyte maturation. Uh, if it's done before 34 hours, then also there will be EFS. If it's done after 38 to 40 hours, then also there are chances of having EFS, because if it's done before 34 hours, then the oocytes are adhered to the cumulus. Oocytes are adhered to the cumulus very tightly. And if it's done after 40 or 38 hours, then the oocytes ovulation has already occurred. Now we won't get any oocyte in the follicle. Ovulation has already occurred. So timing is very important. And in ovarian torsion, if there is unilateral EFS, it can be due to the ovarian torsion. And in ovarian aging also, it is said that in ovarian aging means in there is defective folliculogenesis. Defective folliculogenesis. So follicles will be tightly adhered to the cumulus. There won't be cumulus expansion. So that's why we won't be able to get oocyte. Okay. Defective granulosa cell function, same mechanism. Faulty oocyte development, same mechanism. Okay. That we won't be able to get the oocyte, which you usually get after the cumulus expansion. This is the mnemonic. Incidences 0.045 to 7%. 7%. Impact is cycle cancellation, and there will be stress and anxiety to both the patient and the clinician. It's a very drastic, like in IVF, if there is empty follicular syndrome, it's very tense for the clinician also, but they will explain to the patient. Then key factor influencing variability, HCG concentration threshold for defining EFS. I've already told that there is 5 to 160. There is no standardization. So there is no value has been decided that, okay, after this value, we can say this is optimal HCG. Okay. Choice of the patient population, poor responder and older patient, it is said that there is more chances of EFS. Then challenges is uncertain definition led to inconsistent reporting. Okay. Then some study says this much is the incidence, some study says that much is the incidence. So we cannot decide on the incidence because of lack of standardization in the defining genuine and follicular EFS. Prognosis after EFS. Some studies said that it is a sporadic event. It is not, it is a sporadic event with good clinical outcome in most of the cases, except they said 15% of the cases it is recurrent. Other than that, it is a sporadic event, means in the next cycle there won't be any EFS. Okay. And in another study, it was said that 20% is the recurrence rate. Other study says that it has poor outcome in subsequent cycle. Factor influencing EFS incidence. Patients means like poor patients, responder patient, poor responder patient, and older patient are basically considered to have EFS. Okay. Protocols. Some protocols like mini flare protocol are considered to have more incidence of EFS. And I think why mini flare protocol has more incidence, because mini flare protocol is used for older and poor responder patient. So patient population and EFS more common in older population and poor ovarian reserve. Exclusion of poor responders can underestimate true incidence. Now there are three studies explained here. First is Kim and Z's. In this, it tells about agonist and antagonist protocol. Okay. And it has excluded the poor responder. It says that agonist and antagonist protocol both has similar prevalence of EFS. Second is Madani and Jahangiri study. It says that EFS prevalence is more in mini flare protocol. Mini flare protocol has more EFS prevalence. It might be because of mini flare protocol is mostly used in older patient and poor responder patients. Okay. And third study,
Castillo et al. It says that egg donor, it took egg donor patients, vs own egg patients, and it says that there were similar EFS prevalence. Then another study is Blesquez et al. Blesquez et al. It took considered only egg donor cycle. Prevalence of EFS was 0.59%. In this, it defined GEFS as HCG 10 to 20 international unit per liter, or LH less than 8 and progesterone more than 3.5. These two values at oocyte retrieval. Then it says it is genuine empty follicular syndrome, but it is contradicting the definition of genuine and empty follicular syndrome. In genuine empty follicular syndrome, LH should be optimum. Optimum means greater than 15, 12 hours after trigger, and HCG optimum at oocyte retrieval. Okay, HCG optimum at oocyte retrieval, and LH should be optimum 12 hours after trigger. This is the definition of genuine empty follicular syndrome. In this, it is contradicting the previous definition. In this study, they took genuine empty follicular syndrome as this, like they defined it like this. Okay, now etiology of empty follicular syndrome. First is either HCG or LH level is low. How can this is etiology of false? First, we are talking about false empty follicular syndrome. Okay, false empty follicular syndrome. So if HCG or LH is low, it may be due to either dose is inadequate, or administration, we are administrating it wrongly, error in administration, or error in device setup. See, as we can see, some device setup is needed. So error in device setup, or timing, either too early, that means 34 hour before 34 hour, or too late, that means more than 38 hour we have taken. All this may decrease HCG and LH level, which can cause fall empty follicular syndrome. Okay, now second is industrial defect. See, HCG should be stored in 2 to 8 degrees Celsius. Okay. See, it's written, no? Stored between 2 to 8 degrees Celsius. Do not refrigerate. It should be below 25 always degrees Celsius and away from light. So if it's not stored like this, it can be defective and can cause false empty follicular syndrome. So it will reduce the in vivo biological activity due to manufacturing defect, improper storage conditions. Okay. Third is technical error during oocyte retrieval. Technical error either due to low air pressure or air leakage. Either pressure is low, or this is vacuum pump. No, here pressure is inadequate. Okay, or there is leakage somewhere in the system. Okay, during the oocyte retrieval, if there is leakage somewhere in the system, or pressure is inadequate, then we'll call it technical error, and it will cause false empty follicular syndrome. See, this is vacuum pump. Okay, this in oocyte retrieval we'll learn about this all. Then what is pharmaceutical industrial syndrome? pharmaceutical industrial syndrome. Either error in administration of trigger or timing is wrong. False empty follicular syndrome with HCG trigger called as the pharmaceutical industrial syndrome. Okay, this is given in Kamni Rao. So either error in the administration or timing is improper, some manufacturer defect is there, or there is low bioavailability. Low bioavailability of the drug. How can there be low bioavailability? Either bariatric surgery. Bariatric surgery is there. Surgery. So there will be abdominal skin redundancy, means there will be loose skin. So there will be loose skin. Loose skin. So subcutaneous injection won't work. Okay. Subcutaneous injection won't work. We'll have to give intramuscular injection. Second is either there is rapid liver clearance. Then also there will be low bioavailability. Okay, rapid liver clearance of HCG due to de-acylation of HCG molecule can occur in other patient, or there is ovarian low bioavailability of HCG. Okay, ovary mein HCG is not working. Ovarian mein it is not working. HCG is not working. Then also these are the factors causing the pharmaceutical industrial syndrome. Okay. Now, false empty follicular syndrome with GnRH agonist trigger. See, with GnRH agonist trigger, either it can be wrong because GnRH agonist trigger should not be given in hypogonadotropin. It should not be given with agonist protocol, and it should not be given in overly suppressed pituitary. If we give GnRH overly suppressed pituitary, like if we have already given OCPs for longer time, then GnRH agonist trigger should not be given. So in these three conditions, GnRH agonist trigger should not be given. If we give GnRH agonist trigger in these conditions, then empty follicular syndrome will occur. Now, etiology of genuine empty follicular syndrome. First is genetic, okay? Genetic, it can be due to JP1 mutation. Jonapellisuda 1 mutation. Or it can be due to increased expression of pro-apoptotic gene, or LHCGR gene mutation, or chromosomal 2 inversion. These are all genetic causes. Okay. Then it can be LHCGR sensitivity and signal transduction. Okay. LHCGR sensitivity and CGR sensitivity and signal transduction. Ovarian aging, poor ovarian reserve, faulty oocyte development and maturation, environmental and physiological factor. What is LHCGR? LHCGR is luteinizing hormone and gonadotropin receptor. मतलब HCG और LH के receptor को we'll see LHCGR. Either इसका जो सेकंड पॉइंट है वो बोला कि ट्रांसडक्शन LHCGR तो ठीक है, बट जो बाकी का मॉलिक्यूल है जो ट्रांसडक्शन है दैट इज फॉल्टी. ट्रांसडक्शन इज फॉल्टी, or either LHCGR is gene mutation is there, so it won't work, or transduction is faulty. Okay, so first of all we'll talk about genetic mutation, JP1 mutation. Due to JP1 mutation, there will be defective oogenesis and folliculogenesis, and there may be anti-JP1 autoantibody, So because of this, because of these things, there won't be there won't be maturation of oocyte, and they won't get detached. We won't get any oocyte retrieved. So this is the cause of genuine empty follicular syndrome. This is a paper which tells about the JP1 mutation. Second is pro-apoptotic gene expression. What are the pro-apoptotic gene? If like PAP-A and MAP kinase decreases and pro-apoptotic gene increases, see what PAP-A is doing. PAP-A is inhibiting IGF binding protein, means free IGF will be more if there is PAP-A, and IGF is responsible for growth and proliferation. So if PAP-A is working, there will be growth and proliferation. If PAP-A and MAPK is decreased, there will be these genes are essential for normal follicular growth. Okay, and PAP-A, like we can see, is inhibiting here. PAP-A is inhibiting uh, IGF binding protein. So free IGF will be more, so there will be proliferation. Okay. If this condition happens, decrease in PAP-A and MAPK and increase pro-apoptotic gene, so what will happen is there will be apoptosis during late folliculogenesis. Okay, there will be apoptosis during late folliculogenesis. This embryo will lead to loss of oocyte during late follicle due to apoptosis. Okay. Third is LH-HCG receptor mutation. Receptor polymorphism or mutation. So what happens is, if see LH-HCG receptor, we can see LH-HCG receptor, if it gets polymorphism, if there will be mutation or polymorphism in this receptor, it can be irreversible. Repeat HCG won't work. Okay. It is irreversible, and see, it's written here. It is irreversible, and administration of HCG, repeat administration, because the treatment will be of if EFS is empty follicular syndrome is rescue dose will give of HCG. Okay, rescue HCG dose we give. But in this, it won't be effective because it is irreversible pathway blockade. Okay, irreversible pathway blockade. And specifically, the mutation is of PN400S mutation. Okay, it was found in it is a recessive trait. It was found in two sisters. It was found in two sisters with genuine empty follicular syndrome. Now, chromosomal abnormality. Chromosomal abnormality first is pericentric inversion of chromosome 2. This chromosome 2 is also linked with premature ovarian insufficiency. This chromosome 2 is also linked, means there is some link between premature ovarian of insufficiency and EFS. Okay. Now, genetic predisposition and HCG response in EFS. Okay. Now, what see two things which is happening here. Okay. First is partially impaired follicular response to HCG. We give HCG and there is not much response. So if we'll give rescue dose, if we'll repeat the dose, okay, it will work. Hai, because there was a resistance in the ovary to HCG. There was partial resistance in the, if we'll give repeat dose, it will work. Now, second one, it is saying that there is a slow response. So if we'll take more hours, typically 36 hours. Some patient may need more than typical 36-hour post-STD to achieve full follicular maturation. So traditionally, oocyte retrieval schedule might not be sufficient for these patients. It means to say it is individualized. Some patient take more time for oocyte maturation. So we need to do oocyte retrieval slightly later in these kind of patients. Then now is prolonging interval between ovulation trigger and OPU. Same thing it is saying. In natural cycle, LH surge occur 34 to 46 hour prior to ovulation. Like in this ovulation ये इधर हो रहा है. Here ovulation is taking place. So LH surge will start 34 to 36 hour prior. Okay. LH surge. HCG timing. Exogenous HCG causes follicular rupture approximately 37 hours. Meiosis. Exogenous HCG will give from the outside HCG, then it causes follicular rupture after approximately 37 hours. Meiosis begin 18 hours after LH surge. Meiosis actually begins after 18 hours after LH surge. LH concentration must be maintained above threshold for 14 to 27 hours. This is very important. LH threshold should be maintained for 14 to 27 hours to maximize the oocyte maturation. Follicular maturation and oocyte maturation is a time-dependent process and varies for different women. Some women cumulus expansion take longer and EFS may result when aspiration is done 34 hours after HCG. Means some patient take longer time to for oocyte maturation. We should consider delayed oocyte retrieval. Okay. And now LHCGR sensitivity and signal transduction. See, receptor sensitivity. This is LHCGR receptor. LHCGR receptor. LHCGR receptor is luteinizing hormone chorionogonadotropin receptor. Okay, iski receptor sensitivity and this receptor sensitivity and signal transducing pathway. After LH or HCG get attached with this receptor, then the signals will be transferred. No signals transferred that get inefficient signal if there is insufficient transfer of the signal or there is receptor sensitivity hampering. Okay, there is less receptor sensitivity, then there will be problem. Okay. Dual role of FSH in establishing the EGFR signaling axis in ovarian follicle. FSH induces granular. Okay, what does FSH does is FSH in there is dual role of FSH. Okay. Dual role of FSH. What FSH is doing? FSH, first of all, in granulosa cell, really induce granular cell. FSH induces granular cell to express both LHCGR, which enable them to release EGFR ligand in response to the pre-ovulatory LH surge. Okay. This FSHR in granulosa cell is telling granulosa cell to express more LHCGR. So when LH surge is there, it will release EGFR ligand, which is important for the ovulatory signals. Okay. Now ovarian aging. Ovarian aging causes poor ovarian response. Ovarian aging causes poor ovarian response. And see, there is granulosa cell. This granulosa cell is in ovarian aging. This granulosa cell may respond normally two hormones, normally two hormones. But means normal follicular development will think, but oocyte fails to mature adequately. Means we'll see in the ultrasound that follicle is developing nicely. Okay, that granulosa cell is responding to the hormone normally, but actually oocyte fails to mature adequately in ovarian aging. जो recurrent EFS increases with the age. As age increases, recurrent EFS increases. And as we saw earlier also that in mini-flare protocol, prevalence of FSH was more because in mini-flare protocol is mostly used in older patient and poor responder patient. We have already talked about it. Huh? Then poor ovarian reserve. Common marker identified between poor ovarian reserve and empty follicular syndrome. What are the common marker identified? First is advanced age. Second is elevated day 3 FSH. These are the common marker identified between poor ovarian reserve and EFS, empty follicular syndrome. Third is low estradiol during stimulation. Fourth is increased gonadotropin dose requirement. Fifth is greater than 14, only few follicle which is more than 14 millimeter in diameter. Few follicle which is more than 14 millimeter in diameter. Then see advanced age, high day 3 FSH, low peak estradiol, and few well-developed follicle are strongly linked to genuine empty follicular syndrome. This was by Eunice et al. Studies, and Bem et al. 2020 also found EFS associated with older patient, prolonged infertility, high basal FSH, all indicator of poor ovarian reserve and poor responsiveness to gonadotropin. Alberto Revilli et al. Experience shows that EFS is about 5 times more common in women over 40 than in younger women, with genuine empty follicular syndrome being the primary contributor. However, EFS can also occur in younger women with normal or high ovarian reserve. Kistopoulos et al. Reported EFS in 6 younger women. Okay, this study reported that it can also occur in younger women with normal or high ovarian reserve. Okay, according to Christopher. Now, faulty oocyte development and maturation. Sometimes this is follicular wall. Okay, this is cumulus oocyte complex. This is oocyte. In this, if there is often a strong attachment of the cumulus cell complex to the follicular wall and dysfunctional signal between cumulus cell and the oocyte, contributing to the faulty oocyte development and maturation. This cumulus cell is strongly adhered to the follicular wall. Okay, and there is dysfunctional signaling between the cumulus cell and the oocyte. This may contribute to the faulty oocyte development and maturation. Pathophysiology of empty follicular syndrome with various trigger. HCG trigger. HCG act as a LH surrogate instead of because HCG is alpha unit is identical to LH. So it can act in LH receptor. So it acts as a LH surrogate. Okay, act directly on the ovary, serving as a surrogate for LH in triggering process. HCG mimic the natural LH surge to induce ovulation. Potential cause of empty follicular syndrome with HCG trigger. What is the potential cause? First is abnormal folliculogenesis. Either follicular development is wrong, okay, or ovary not responding well to HCG. Or error in the trigger administration dose, route, and timing. We have already discussed this. Then pathology, GnRH agonist trigger, inadequate LH release. When will inadequate LH release will be there? Either hypogonadotropic hypogonadism, or we have already used agonist protocol. So there won't be any LH release from the pituitary, or there is oversuppression of the pituitary due to OCP's uses. Or ovarian receptor issues, failure of the ovary receptor to mediate the action of LH. Means there is some receptor for LH is non-functional. Some defect is there in the LH ovarian receptor, or LH beta subunit gene polymorphism. Either this receptor is defective, or there is polymorphism of LH beta subunit gene. Specific patient group prone to EFS with agonist trigger. GnRH agonist trigger say what people are prone to EFS. First is hypogonadotropic hypogonadism patient. Second is means what? FSH and LH basal level is less than 1.2. Okay. Then second is borderline decrease. Borderline decrease means it is not very less, but it is not more also, just above the hypo thresholds. So what will happen in these kind of patient? In this kind of patient, there will be initial follicular development, but because of insufficient LH, there won't be insufficient, later on there will be insufficient LH, so there won't be cumulus cell expansion won't be there, and detachment won't be there. Okay, detachment of the oocyte won't be there. These won't be there because of insufficient LH if there is borderline hypothalamic pituitary dysfunction. Third is temporary pituitary hyposensitivity. If there is temporarily pituitary hyposensitivity, HCG trigger may work. Okay. Pituitary. We can give HCG trigger and that may work. Jamaica insufficient HCG trigger might recover mature oocyte well. Then patient with GnRH receptor polymorphism will, if there is GnRH receptor polymorphism, will have to increase the dose of the GnRH agonist. Then LH beta gene polymorphism. If there is LH beta gene polymorphism, then also it is, I'm talking about it time and again because it is important. If there is LH beta gene polymorphism, homozygous variant, women with homozygous variant have less bioactive LH molecule. This make them at risk for blunted response to GnRH agonist. See, it is from Gardner. We have taken it from Gardner, predicting the probability of not obtaining oocyte after GnRH agonist. Either there is low post-trigger LH. 12-hour, first of all, I think this should be the first point, but okay. If we give trigger and after 12 hour after, we measure LH, and if it is less than 15 international unit per liter, this is, we are talking about GnRH agonist trigger. Okay, so it has more chances of empty follicular syndrome. Then second is suboptimal response correlated with low FSH. If there is, as we have already discussed, if there is low FSH, baseline FSH and LH is low, that means less than 0.1. So there will be probability of not obtaining oocyte after GnRH agonist trigger. Then low LH, less than 0.5 on trigger day. Then long-term OCP use, then also, and low LH at stimulation start. Same thing, it is repeating again and again. These are from different studies. This is taken from the Gardner. And low BMI. This also has a high probability of not obtaining oocyte. Monitoring LH level post-trigger. Monitoring it. One study, post-trigger LH and progesterone level strongly correlate. Okay, according to one study, we saw that LH and progesterone level correlated with total and mature oocyte retrieved. Okay, another like EFS cases had an LH less than 15 international unit and see. So EFS cases had an LH less than 15 international unit per liter and progesterone less than equal to 3.5 nanogram per ml post trigger, 12 hour after trigger. And if LH is less than 15 international unit per liter, the chances of probability of EFS was 18 to 8%. This thing is taken from the Gardner. And another study showed that if LH is less than 15 international unit per liter post trigger is associated with lower oocyte yield. Yet no impact on the oocyte maturity was observed. This was one study and this was another study. See here also it is this one is Kumar et al. Study which says that there is strong correlation between LH post-trigger LH and progesterone level and total and mature oocyte retrieve. Chen et al. Says that if LH is less than 15 and progesterone is less than 3.5 nanogram, then there is a chances of empty follicular syndrome, and probability of empty follicular syndrome is 18.18% if the LH is less than 15 international per unit per liter. And the chances of some study says that if LH is less than 15 international unit per liter, then chances of oocyte is lower, but there is no effect on the oocyte maturity. See, predicting successful oocyte retrieval post GnRH agonist trigger is critical for deciding on retrieval or rescue HCG dose. We have to decide either we have to proceed with retrieval or we'll have to administer a rescue HCG dose. So that's why predicting successful oocyte retrieval is very important. For predicting this oocyte retrieval, I have already told these factors, okay? This factor shows the predicting the probability of not obtaining oocyte after GnRH agonist. Then advantage of GnRH agonist trigger over HCG. GnRH agonist triggers enhances the maturity and quality of oocytes, and early embryo development will be there, okay? And hormonal milieu differ at mature oocyte may contribute to the improved outcome. These are the benefits. First, hormonal milieu. Second is early embryo development, and oocyte quality and maturity is good. Prevention and early diagnosis of empty follicular syndrome. See, early diagnosis of empty follicular syndrome, how will diagnose? HCG will do if we have given HCG trigger and we even after 3 oocyte retrieval, if we don't have any egg oocyte, even after 3 oocyte retrieval, if we do not have any egg, so what we'll do is we'll see the follicular HCG, follicular fluid HCG. Okay, so blood HCG actually takes time, so we'll do follicular fluid HCG, and we'll see in HCG kit. If there is 2 line, that means HCG is more than 20. That means HCG has worked, means we'll continue with oocyte retrieval. Okay. And with GnRH agonist trigger, what will we do? With GnRH agonist trigger, we have to, in this, we have to do this at HCG, we'll have to see after 3 oocyte retrieval also, we did not get any egg, and this should be done during oocyte retrieval. But in GnRH agonist trigger, LH and progesterone should be seen 12 hour after trigger. Okay, 12 hour after trigger, 12 hour post trigger, LH of itna, and 12 hour post trigger progesterone greater than itna. LH should be more than 15, optimal LH should be there, and progesterone should be more than 3.5 nanogram per ml. Post trigger hormone dynamic and then their impact on oocyte retrieval. See, if there is elevated, say, luteinizing and progesterone release, luteinization of the follicle releases progesterone. Higher number of follicles, higher progesterone levels. If there is more progesterone but borderline low LH, then also there are chances of successful oocyte retrieval. Borderline or low LH, but progesterone is elevated, there are chances of successful oocyte retrieval. But if there is low progesterone but LH is more, this may indicate inadequate response. Matlab, progesterone should be more. Okay, progesterone should be more. Even if LH is more but progesterone is less, they may indicate inadequate response. Timing and interpretation of post-trigger LH and progesterone level. So, timing interval and hormone measurement. Crucial to consider the time interval between the trigger and the post-trigger assay, especially for LH. When does LH peak? After giving trigger, when we give agonist trigger. Okay, after 4 hours of giving trigger, this is agonist trigger. Okay, LH will be at its peak. Okay, so occurs 4 hour post trigger followed by a rapid decline. Hormone level, shorter interval, 4 to 8 hours, there will be higher LH and progesterone level. Longer interval, 12 to 15 hours, there will be lower LH and higher progesterone level. Risk of EFS recurrence. Medical history of EFS as an indicator. A history of EFS may suggest an increased risk of recurrence. Some studies says it is 20% recurrence, some studies says 15% recurrence. Some studies view EFS as an irreversible recurrent condition. Some says it is irreversible recurrent condition, some says it is sporadic condition. Other study argue that a first occurrence of EFS does not necessarily reduce fertility potential in future IVF attempt. Key points. EFS might not be a persistent condition that and does not always predict future IVF outcome. Then EFS outcome in subsequent cycle. There was one study in that we saw there was no significant difference found in type of protocol use, type of gonadotropin use, total exogenous gonadotropin dose, length of ovarian stimulation, peak estradiol level at trigger, and type of trigger. Okay, no significant difference was found. There was one study. It is only telling about some studies. Okay. Conclusion: if EFS does not invariably reoccur and patient can achieve successful outcome in subsequent cycle. Predicting EFS before ovarian stimulation. No precise prediction, no exact method to predict EFS before stimulation. Risk factor: older age is a risk factor, poor ovarian reserve is a risk factor, Longer duration infertility increases risk but are not predictive. Okay. Limitation: normal follicular growth and estradiol level may still result in EFS. Even after normal follicular growth and there is good estradiol level, EFS can occur. Sign and indication during stimulation. What are the positive indicators? If there is a normal follicular growth, then it is a positive indicator, and if estradiol level is good and rising, then it is a positive indicator. What is the negative indicator? Warning indicator for premature ovulation. What are the warning indicator for premature ovulation? First is precocious serum progesterone, matlab before trigger only, if serum progesterone is 1.5 picogram per ml, then there are chances that there will be premature ovulation. Type 2 endometrial echogenicity. If there is endometrial echogenicity, it is because of the progesterone, early progesterone exposure. Type 2 endometrial echogenicity, mid-secretory phase of the menstrual cycle. It occurs actually in the mid-secretory phase, means endometrium is ahead. Okay. So that means there will be premature ovulation. So EFS, chances of EFS is more. Then disappearance of bigger size follicle or irregular shape large follicle, means bigger size follicle if disappear means ovulation has already occurred, or if it's irregular shape, that also means that ovulation has already occurred. HCG administration guideline. We should make sure that patient understand the timing and technique for HCG administration. And we should administer HCG when two follicle reaches 17 to 19 millimeter in diameter with appropriate estradiol level. In our place, we consider three follicle. Okay, here it's written 2 follicle according to this study in 2017. Yeah. Considered for PCOS, mature oocyte can be retrieved from smaller, even 14 to smaller follicle, even 14 to 16 millimeter follicle in PCOS can give you mature oocyte. Okay, even 14 to 16 millimeter. Diagnostic step: conduct urinary or blood HCG test before oocyte retrieval. We can conduct urinary or blood HCG test before oocyte retrieval to see if HCG has worked or not. Puncture follicle one by one and confirm oocyte retrieval before proceeding. As I have already told you, after 3 oocyte retrieval, if we don't have any egg, we so do follicular fluid HCG with urinary kit. If it is double line, that means positive, means you can continue. Treatment: false EFS. What is the treatment of false EFS? Either you give HCG, rescue HCG. As soon as you diagnose that there is, we'll give rescue HCG injection. That should be that there is empty. We diagnose as that there is empty follicular syndrome. We'll give rescue HCG. That should be from the different batch, increased doses, and that we can change from the urinary to recombinant HCG. Okay. This we are talking about false empty follicular syndrome. We'll give rescue HCG dose. Then second, retrieval success. While some study report positive outcome with live birth, others have noted lower success rate due to the factor like oocyte post maturity, because we are giving the injection rescue dose now, so there will be post maturity and endometrial receptivity issue, and there will be issues in the endometrial receptivity. Subsequent cycle transfer. In some cases, transferring the embryo in the subsequent cycle after rescue HCG treatment may improve the implantation and pregnancy rate, potentially due to better endometrial receptivity. Lower success rate can be there after rescue HCG dose because of 2 things. One is post maturity, second is endometrial receptivity alteration. Okay. So what we'll do is we can retrieve the oocyte, and later on in another cycle we'll freeze them, and in later on in another cycle we'll transfer them. Now, treatment of genuine empty follicular syndrome. For for false empty follicular syndrome, what we were doing is we were giving the rescue dose. Rescue dose will give either the rescue dose should be given, dose should be more, different batch should be used, or if we have used urinary HCG, then recommended HCG should be used. Okay, this was the treatment for false empty follicular syndrome. Now we are talking about the treatment of genuine empty follicular syndrome. First we'll see the study Yugur et al. This what this did was prolonging the interval between SCG administration and oocyte retrieval. This study prolonged the interval between the HCG administration and oocyte retrieval. So there was no significant improved outcome in the case of genuine empty follicular syndrome, but it saw that we have already talked about it before, that there is individualized treatment. Like some patient can have a mature oocyte later in the, like it may take more time. Some patient may take more time for the mature oocytes. But this study saw that there was no significant improved outcome in the cases of genuine empty follicular syndrome. Second study is Hessen et al. Okay. What does it do? No side were retrieved despite HCG circulating level of 300 international unit per liter. But after another HCG dose, 10,000, a second OPU, 24 hours later. Okay, this is genuine empty follicular syndrome. That means there will be optimum HCG level. Even after optimum HCG level, there were no oocyte retrieved. So another HCG bolus was given with the 10,000 international unit, and OPU was done 24 hours later. So they retrieve 7 mature oocyte and can so administering a rescue HCG bolus after initial unsuccessful retrieval can lead to successful oocyte retrieved and fertilization, but it requires careful timing and may not always be effective. Okay, even in genuine empty follicular syndrome, we can use rescue HCG doses. Because sometimes there is receptor polymorphism which needs more doses. Okay. Then Locke et al. What it does is rescue HCG bolus after unsuccessful retrieval despite circulating HCG level. Multiple attempts with different protocol. No oocyte retrieved after repeated cycle. Finally, achieve oocyte retrieve with GnRH antagonist protocol, but no pregnancy. Suggest endogenous. Means first it was using multiple cycle. It used HCG as a trigger. Even HCG circulating level was good. Even after that, multiple attempt with different protocol, they did not get any oocytes. Okay, they were finally what they did was they changed into GnRH antagonist protocol and they give agonist trigger. They change into GnRH antagonist protocol and they give agonist trigger. So GnRH antagonist protocol in some patients switching to GnRH antagonist protocol can eventually lead to oocyte retrieval after multiple failed attempt. This suggests that an endogenous LH stimulus by GnRH agonist trigger might be more effective than exogenous HCG in certain cases. There is no one-size-fits-all solution for genuine empty follicular syndrome. Means after many HCG trigger cycles, they tried one GnRH antagonist cycle with GnRH agonist trigger, so it worked. Okay, so there is not one size fit all solution for genuine empty follicular syndrome. Then Beck-Frucher et al. 2012, what the initial cycle with HCG only resulted in no or only immature oocyte retrieve. Subsequent cycle used GnRH agonist 40 hours before, means they give dual trigger. These two study talks about dual trigger. This Beck-Frucher et al. 2012, they give dual trigger GnRH agonist triptylene acetate 40 hours before they gave, and HCG they gave after 34 hours before oocyte retrieval. This is oocyte retrieval. This HCG agonist, GnRH agonist was given 40 hours before, and HCG trigger was given 36 hours before. Okay, 36 hours before the oocyte retrieval. 18 oocyte retrieve. Before there was no oocyte retrieve or only immature oocyte retrieve, but now 18 oocyte retrieve, 16 mature, 11 embryo developed, 2 transfer resulted in singleton pregnancy. Dual triggering with GnRH agonist and HCG improve outcome in EFS. That means dual triggering is helpful. Has at all investigation of mRNA expression changes in granulosa cell after dual triggering with HCG and GnRH agonist compared to HCG alone. Significant changes in mRNA expression of amphiregulin and epiregulin suggesting improved oocyte and embryo quality with dual triggering. Support the efficacy of dual triggering on the molecular level, indicate potential for improving oocyte and embryo quality. Now see, 4 things are there. Either in genuine empty follicular syndrome, either we can use rescue HCG dose, or we can try, if we are using the, or we can use GnRH agonist trigger with rescue HCG. This method is used more frequently in, okay, GnRH agonist trigger if we have already used and it is not working, means we are not getting any oocyte, so we can try by giving rescue HCG. We can give HCG, and after 24 hours after we can retrieve. And this method is used most frequently in high responder to reduce the risk of OHSS. Then dual trigger may be used. Okay, dual trigger approach may be used. These things need further research, unknown physiopathology, and no well-defined treatment. Here, one more we should have written that if we are using HCG already, okay, we can change the protocol. We can change the protocol into GnRH antagonist protocol with GnRH agonist trigger. We can change the protocol, and that may help. Retriggering protocols. See, now this is for GnRH agonist. If no oocyte retrieved from one ovary, we will retrigger with HCG and we'll reschedule oocyte retrieval after 34 hours of rescue HCG dose. Okay. We have given GnRH agonist. Okay. This is the day for this. We have given GnRH agonist. This is the day for oocyte retrieval. This is from Gardner. Okay. So there is no oocyte retrieved from one ovary. There are 2 schools. Some says do 3 oocyte retrieval and then see for the if egg is there or not. Basically, we do that for HCG, because if there is no egg retrieved after 3 oocyte we pick oocyte pickup. Even after 3 oocyte pickup, we did not get egg. So what will we do is we'll see from the follicular fluid the HCG. We'll put it in the urinary HCG kit, and if it's positive, that means HCG is in optimal amount. Okay, so we'll continue the oocyte retrieval. But when we are giving GnRH agonist, we'll do from the one ovary, we'll do oocyte retrieval. If there is no ova retrieved, then we'll give the rescue dose. We'll give the rescue HCG dose, and after this rescue HCG dose, after 34 hours after this, we'll plan our oocyte retrieval for another ovary. Okay, this was first. Second scenario is we'll see post-trigger serum LH monitoring we'll check for LH and progesterone. We'll check for LH and progesterone. If there is no LH and progesterone surge, we'll retrigger it with HCG. And same after HCG retrigger means we'll after 12 hour after this we are giving GnRH agonist. Okay. 12 hour after we'll see for LH and progesterone. If there is no search for this, means LH is less than 15 and progesterone is less than 3.5, then we'll give oocyte and we'll give HCG rescue dose. Okay. And 35 hour after this, we'll do the oocyte retrieval for another. We'll do the oocyte retrieval. Okay. Not for another ovary. That was first scenario in which we are doing from one ovary, and if we are not getting, then we are giving rescue HCG. In this, we have already predicted that there can be empty follicular syndrome. So we after GnRH, after giving GnRH agonist trigger, 12 hour after we saw for LH and progesterone level, and if LH level is less than 15 and progesterone level is less than 3.5, we already have predicted that there can be chance for empty follicular syndrome. So we give HCG rescue dose, and 35 hour after HCG rescue dose, we retrieve the oocytes. Okay. Then third scenario is if there is LH surge but suboptimal. Means there is increase but less than 15. So we have two scenario here. Either we can retrigger it with HCG as soon as possible and planned it with the GnRH agonist trigger. Means after GnRH agonist trigger, we were going to 12 hour after we saw for LH and it is less than 15. So we usually do oocyte retrieval after 37 hour of GnRH agonist trigger. So we'll continue, but when we saw that LH is suboptimal, means it is raised but not according to the mark. So we give HCG here, but the planning of retrieval won't be according to this HCG. Planning of retrieval will be according to the GnRH agonist trigger. That means 37 hours after GnRH agonist trigger. Or we can cancel this cycle, or we can consider to cancel this cycle. Same thing it has been told in the flowchart form. Now, physiology, natural vs GnRH induced mid-cycle surge. See, in natural surge, what happened? LH rise for 14 hours, then there is a plateau for 14 hours, then decline for 20 hours. That means total of 48 hours. With GnRH agonist, plateau phase is not there, and it rises and then decline, rises for 4 hours and decline within 20 hours. So total of 24 to 36 hours. It is timing is less. See here 48 hours natural physiology में LH rises 48 hours. Total of LH is total rises for 48 hours. LH, but in GnRH agonist cycle for 24 to 36 hours. So it causes maturation, ovulation, and ovulation occur normally, but there is CL defect, corpus luteum defect. Because GnRH agonist trigger surge is shorter, potentially affecting the corpus luteum formation. Then, okay, I have already explained this. Defective corpus luteum formation. GnRH agonist triggering for final oocyte maturation. In GnRH, there is LH and FSH surge simultaneously, like the natural cycle, unlike HCG trigger. So advantage of FSH surge. What are the advantage of FSH surge? First, FSH may induce LH receptor formation in the granulosa cell. Okay, LH receptor formation in the granulosa cell, which and promote oocyte nuclear maturation and cumulus expansion. Oocyte maturation and cumulus expansion. Okay, all this is done by FSH. Second is, we are talking about why, what are the advantage of FSH surge? Because when we are using HCG trigger, there won't be FSH surge, there will be LH surge. But when we are giving GnRH agonist trigger, it is like a normal natural cycle, and there will be both FSH surge and LH surge. Okay. Second, gap junction maintenance. There will be gap junction between oocyte, open gap junction between oocyte and cumulus, helps in signaling pathway. Okay. FSH helps keep gap junction open between oocyte and cumulus, aiding signal pathway. Third is FSH stimulate plasminogen activator activity in granulosa cell, leading to follicular wall disruption through plasmin and collagenase production. Third is plasminogen activator is stimulated by FSH, so there will be plasmin formation and collagenase production, which will cause follicular wall disruption, which help in ovulation. Fourth is expansion and dispersion of cumulus cell to form oocyte cumulus mass involves hyaluronic acid matrix stimulated by FSH. Okay, so FSH stimulate cumulus cell to produce hyaluronic acid and other extracellular matrix. So the expansion and dispersion of cumulus cell are primarily driven by formation of hyaluronic acid rich extracellular matrix. Okay, expansion and dispersion of cumulus cell. So it is required for ovulation. Okay, thank you.